Okay, so let's go ahead and get started again. This is what do you do when the pain medications don't work. I work with a doctor named Dr. Michael Johnson, who's the author of this book, actually. What do you do when the pain medications don't work? A non-drug treatment of dizziness, migraine headaches, fibromyalgia, and other chronic conditions. So basically, this gentleman wrote the book on chronic pain. So let's just get started. A little bit about me. Obviously, I'm a chiropractic physician. I have a Bachelor of Science degree. I've been in private practice here since 2005. I've done mission work in different countries, such as Trinidad and El Salvador. I am what we call a chiropractic neurologist. What that means is I'm obviously a chiropractor first, but I specialize in neurology. There's actually a diplomat beyond that, which is what I hold. There's three of us, excuse me, in the state of Virginia. There's myself. There's one in D.C. and then there's another one in the Virginia Beach area. So there's basically three of us. What the difference is this. If you go to a medical neurologist, and let's say you have a migraine headache or you have a dizziness issue, he's going to run some tests, possibly an MRI, provide you with a medication. So for example, if you have a dizziness, he might give you something like meclizine or an antivert to help you with that. Okay? Whereas if someone comes to me and has dizziness or BPPV, paroxysmal positional vertigo, I'm going to assess their balance system, the vestibular system, and then if I find some weaknesses or discrepancies in that system, I would prescribe some rehabilitation exercises based off of that. So we're looking at the same thing, I just basically handle it naturally. That's the differences between what we do. So because of that, we see a lot of different cases in here. We treat some tremor disorders, we treat some Parkinson's cases, we treat kids that are autistic spectrum, we see some ADHD kids. There's a lot of different things you wouldn't normally associate with chiropractic, but this is chiropractic neurology. It's a different way of approaching things. I'm currently enrolled in taking Dr. Robert Melillo's course. He's the author of a book called Disconnected Kids, which deals with ADHD primarily and autism. Okay, and again, that's some of the cases we take care of in our office. I've studied functional blood chemistry and functional neurotransmitters under Dr. Datis Karazian. He is a pioneer in what we call functional nutrition. Great book out right now called Why Do I Still Have Thyroid Symptoms When My Lab Tests Are Normal? So he's a leader in functional nutrition. And what that is basically analyzing your blood work, analyzing your tests, and telling you what you need to do nutritionally based off of this, as opposed to giving you a pharmaceutical agent. Again, we covered this already.
Is there any connection, excuse me, between all these drugs that they've given? Because I've been on every drug that there is almost, and now I have thyroid problems. Is there any?
Well, I'm going to explain that a little bit more.
Okay.
Is there a connection? Possibly. Chances are good you probably have some other thing going on, some kind of sensitivity going on, which is finally starting to attack your immune system, and being your thyroid. You were diagnosed with Hashimoto's, or a hypothyroid, a sluggish thyroid?
Yeah.
Yes, and usually 80% of those are Hashimoto's. So hold that thought. We'll get back to that question in a little bit. Certified interactive metronome. I'm the only one certified in the area with interactive metronome. Interactive metronome, it's a device we use. You guys know what a metronome is, right?
Yeah.
Keeps beat.
Yeah.
Okay. We use this to retrain the brain. So this is what we use on one of our brain cases, post-stroke, our ADHD kids. So the kids or the individual see a light up, something light up on the screen, and they have to either clap their hands or tap their foot to the beat. And if they're too fast or too slow, they get an automatic feedback from that. Sounds easy, but we can decrease it and change the speed of it. It's very difficult. It actually retrains and remaps the brain. Pretty interesting stuff. I'm currently working towards what's called my CCSP certification, which is a sports physician degree through Dr. Moreau. Dr. Moreau is the actual physician for the Olympic team. So another degree that I'm currently working on. I'm also certified through the Spine Research Institute of San Diego in whiplash and brain traumatology. It's another area of study I hold in the area that no one else does. It's basically enables me to deal with post-traumatic injuries as far as whiplash goes. So enough bragging about that. That's just some of the things that I do to keep myself busy and learn more about chronic health conditions. So when we're dealing with chronic health conditions, they're all going to have some kind of common thread, whether it is fibromyalgia, sciatica, peripheral neuropathy, which we see a lot of in here, migraines, digestive disorders, chronic neck pain. They're all going to have some of this in common, whether it's an oxygen deficit, metabolic imbalances, and primarily this is a huge thing when we're dealing with individuals that have migraines is there's metabolic issues, things such as dysglycemia, cortisol imbalances. We'll talk more about it in a little bit. And neurological misfiring, whether it's from aberrant input from the neck or other areas. So I treat migraine headaches the same way I treat peripheral neuropathy, the same way I treat sciatica, the same way I treat ADHD. Okay? There's some kind of neurological involvement and there's some kind of metabolic involvement. Do you understand what I'm talking about here? Neurologic and metabolic. Okay.
I get that in neurology. What is metabolic?
Metabolic is how your body compensates, basically how you're eating and digesting and these type of things. Okay. Your blood work and your labs and your sensitivities. So there's basically a combination between the two. Yours might be 80% neurologic and 20% metabolic. I don't know, but everything has this kind of common thread involved. So one of the main things that we need to ask ourselves when we're dealing with this type of case is, number one, what's the cause of your migraine? Why? You have migraines, you have headaches. Why? Do you get headaches? Oh, excuse me, that's the wrong button there. Do you get headaches because you lack Tylenol in your bloodstream?
No.
No, we don't get. There's got to be a reason, right? Do you understand the mechanism behind it?
No.
Okay, pretty simple. Okay, somewhere in the body there's an increased need for fuel. So let's say it's up here in the brain. That's where it happens. Okay, so you have an increased need for fuel. So the body has to get more blood there to that area to get that demand met. Okay, so it releases something called a neurotransmitter. Okay, things such as calcitonin, bradykinin. These things are released. And if they're released normally, we get what we call vasodilation, which means the blood vessels expand so we get more blood to the area. Okay? In a migraine case, guess what happens?
It's too much. It's strict.
It doesn't happen at first. Okay? That's why you get the spots, you get the aura. Okay? You smell things that aren't there. It's called what's called a transient ischemia. That's the prodrome. So in other words, you need the increase in blood flow. You're sending messages for it to happen, but it doesn't happen. So we're lacking blood flow for a while here. That's why we start having these things go on. So what happens is you get more and more of those neurotransmitter release saying, hurry up and get that blood up there. We need to fix this problem. And they do that, what happens? We get overdilation. It expands too much. And then there's these nerve fibers that cover the vessels. And then these nerve fibers get stretched, specifically your trigeminal nerve, which is one of your cranial nerves. And that's what causes that pain that people feel. So when people get the headache, that's really a symptom of what's going on. Of the cause is the vessel problem in here. Does that make sense?
I'm following, but I have a migraine
right now. Okay, all right, okay. Eventually, what happens is another part of your nervous system called your sympathetics fires. Okay, your sympathetics help constrict that blood flow, and they fire to help calm the situation down. But obviously, it's not very comfortable during the meantime while you're having this. So that's really the cause. Now, if we look at this from a metabolic aspect or a neurological aspect, there's a place in your brainstem, kind of located right up and through here, called your mesencephalon, or your midbrain. It's part of your brainstem area. And oftentimes in these cases, we're finding that area is working too hard. This mesencephalon is very well connected with what's called your sympathetic nervous system. Your sympathetic nervous system is your fight or your flight part of your nervous system. Case in point, I'm walking in the woods and I see a black bear in front of me. I've got two options. My options are either I can fight or I can run away. So how many people are thinking about eating a meal and relaxing when they see a black bear? You're not. Your parasympathetics aren't working. Your sympathetics are. So you're geared up, you're ready to run, you're ready to fight. That's what's going on. So do you think that that part of your nervous system should be firing frequently or predominantly in your body? Of course not. That's not normal. We can't live in fear like that all the time in stress environment. But unfortunately, when we're dealing with migraines, this is usually what's going on. That's why these people have difficulty with lights. They have difficulty with sleeping. They have difficulty with all host of things because this mesencephalon is just ramped up and working all the time more than it should. So that's the neurological aspect of it. So again, rebound overdilation, the throbbing pain, and light sensitivity. Okay, so we know how migraines work now, a little bit about it. Why are they happening? That's the question.
I've been to a lot of places and no one's been able to tell me why migraines.
There's no one cause. That's the problem. It's like I said in the beginning, it's a couple different things, and that's why. Okay. Number one, we know it can be abnormal neurological firing, meaning the wiring is not going through properly. Okay, that's something we have to assess and figure out why. It can be from some kind of trauma or spinal issues. We know when some people have whiplash or different things that affects the neck and the actual vertebra in the cervical spine, that can affect migraines as well. So what happens is when you have abnormal firing in these joints, when you move your neck, you should get a proper firing back up to the brain to tell where each joint's positioned and how it's working. But if we move our neck and it's constantly causing pain, we bombard our brain with what's called a nociceptive input or a pain input. That can lead to some of these problems. Okay? TMJ, temporomandibular joint problems, usually accompany migraine headaches as well. That can be contributing or causing the other one, vice versa. It just depends on the individual. This is a huge one, folks, and this is often the one that's most of the time overlooked is the metabolic or sensitivity aspect of this. Okay? Case in point, I had a patient come in to see me, come in here for a herniated disc. And we treated him with some of our machines in here. But basically, we treated him for his herniated disc. He goes on to tell me after we're treating him, while we're treating him for his back, I get headaches every day. I don't know why. So we dig a little bit deeper in his history. We started working on his neck, and his neck didn't feel really too bad. We started treating him, and his headaches weren't going away. I thought, this doesn't make sense. We got a little bit deeper. He was drinking a 2 liter of Coke every day. What does that do to your body? That absolutely is destroying. Dysglycemia, abnormal blood sugar. These vessels don't know what to do. We got him off the Coke, headaches went away. Metabolic is often the missing aspect. I'm not saying that that's the cause of everyone's headache because they're drinking. But you understand what I'm saying? This is often the missing link in these things. Sensitivities is often the missing links. We'll talk more about which foods are sensitive, the most predominant ones, and why, and what this can do to you. So we know we need 2 things for our body to function normal. We need fuel, we need activation. Fuel comes in the form of the foods that you eat, a proper, steady supply of glucose or sugar, okay? And the air we breathe, such as oxygen. We utilize oxygen therapy in this office. Another example, had a migraine patient, a young man, actually was a chronic headache patient. He had, when he came into our office, 18-year-old man, he came into our office, he had had headaches for the last 1.5 years every day. And he'd been to the medical doctor, he'd been to the neurologist. No one really knew what was going on. So every day he had a headache, every day he had a headache. He came into our office, we checked his oxygen saturation. His oxygen saturation was at 91%, okay? Normal is 98 to 100. So the first thing I said, we gotta give him on oxygen, okay? So we got him on oxygen, we started treating him, doing some work on him. Within 2 weeks, stopped having headaches, did not get any more headaches at all. Okay, this took care of that, that was a problem. So my question to you is this. The headaches were really just a symptom of what's going on underneath the hood with this gentleman. What if this would have happened for 30 more years? Oxygen deprivation for 30 more years. What do you think his whole health status would have been like? Absolutely horrible. I was watching ABC, I think it was ABC News, a couple months ago, and there was a special, there was a neurologist on there talking about, we found a breakthrough treatment for migraine headaches. And guess what it was? Oxygen therapy. Okay? We're seeing great results with this. Well, guess what? We've been doing this for a while now. We know that it works. It's part of our treatment. You've got to give the body fuel for what it needs. Once you can give it fuel, you can activate it as well. Activation is like exercise for your nervous system. Okay? So we're receptor-driven individuals. So what I mean by that is you're constantly, your brain feeds off of its stimulus. So back to the neck pain example. If I can't turn my head to the left for a period of time, that part of my brain that represents that turning to the left is going to get weaker and weaker because I'm not using it anymore. If you don't use it, you lose it. They did some research with some college kids. Because college kids will do about anything for money, right?
Yeah.
I did, we were all there. But what they did is they divided them into 2 groups. And they looked at their right lower leg, okay, or the right extremity, lower extremity. Now the area that represents the right lower extremity is what's called the left somatosensory cortex and the parietal lobe, which is up and through here. So what they did is they kind of mapped this area up in the brain to see how it was firing and functioning and performed some tests. And the one group, they measured the beginning, and then they put a cast on that leg. Another group, they measured the beginning, and they didn't do anything with the leg. And they did this for about 2 weeks. The cast was on for 2 weeks, and the other group didn't have anything done. So within 2 weeks' time period, they measured that area of the brain again. What do you think was different between the 2?
Less activity.
Exactly. Less activity because it's immobilized. Same kind of thing. It's the same kind of thing with these chronic pain patients that are dealing with these things. There's less activity from the extremities and from your environment. There's going to be less activity in the brain. That's important. Very important concept. Okay, so this is your nervous system. Basically, it's telling us it's composed of the brain, spinal cord, and all the nerves that come from it. Okay, so we know that if you look at this chart right here, we have the brain sits up here, sends messages down through our spinal cord, and then all branching off into the hands. We've got nerves that go into our hands. And then further down we go, we got the nerves that branch into our lower legs. And these are our motor nerves and sensory nerves. But we also have nerves that go into the internal areas of our body as well, and that's what this is talking about. And it's all really dependent on what goes on top here in the brain. Everything is dependent on what goes on up here. Okay, it all functions from that area. And this just talks about that a little bit more in detail. Shows what we talked about here, the nerves branching off the spinal cord. Kind of like wires, okay? Telling each area what to do. And then again, you got areas that go to your heart, your lungs, and your stomach bowels as well. And your brain's going to make decisions based off the information it receives. Gets bad information, bad decisions. Simple. Okay. So if we look at an actual side picture of the brain, there'll be a test on this, so make sure you guys write this down. No good. Not a good joke that time. All right. Okay. So we got the front part here, what's called the frontal lobe. So we're looking at a side picture like this of the brain. We got the frontal lobe right in through here. Oftentimes, when people have a ramped up, what we call mesencephalon, or that area of the brainstem we said was really firing too much, oftentimes what's happening is this area is underdeveloped and not working as well as it should. So there's different brain-based therapies we do, interactive metronome, visual, eye exercises, things like that, to increase the function, the firing of this area, to calm that guy down. That mesencephalon is kind of like an unruly teenager that just wants to keep acting up. It needs someone to keep it in check. It needs that mature mom and dad to keep it in check. And that's what that frontal lobe does. Another thing this frontal lobe does is this is basically what separates us from animals. This is our thinking, our processing. If I eat this today, how's this going to affect me tomorrow? Our ability to function in social situations, ADHD, ADD, these kind of things, huge frontal lobe issues. That's why we have to fire when we have problems with that. Your parietal lobe we already talked about. That's the sensory area. So if I smash my right toe, I feel that up here in the left side of my brain in my somatosensory cortex. C right here is what's called our temporal lobe. Okay, that's our hearing, that's our memory, that's our smell terminates here. Heschel's gyrus is located here. Okay, D, that's what's called our occipital lobe. That's where our vision terminates. So we see things that comes back in through here, goes back in through our lateral geniculate body and back in here to our occipital lobe. We have our cerebellum down in here. Works in conjunction with this frontal lobe. Okay, the cerebellum. Have you guys heard of someone getting their bell rung? Mm-hmm. Yeah, you get hit so hard you're kind of wobbly. Because the cerebellum's been affected. It has a lot to do with our balance. People that have cerebellum issues have problems with fine motor movements. And they have problems with usually core muscle stability, so spinal complaints. Most everybody that comes in here with a bad back usually has a weak cerebellum because their cerebellum can't fire enough properly to keep the muscles straight. Okay. Okay, so who wants to label them? Anybody, no takers on that one, huh? Okay. So again, we kind of covered this already. This is that mesencephalon, the brainstem we're talking about. This is kind of an inside slice. If we were to take the brain and kind of cut it in half from the side, that's where that midbrain of that mesencephalon would be. It's the top part of the brainstem. Okay. So the way things should work in the network is we get feedback from our external environment, which goes into the cerebellum, okay, which is transferred to the brain, which goes to that lower part of the brainstem, and that all keeps that upper brainstem in check. Okay, that's the way things should kind of work for us. But when that upper brainstem gets or not modulated properly, that's when we talk about that sympathetic fight or flight nervous system starts kicking in more and more. Also, what's located here is what's called your reticular activating system, which is responsible for you being awake and alert. So again, one of the problems when this mesencephalon is firing too much, it results in these migraines, it results in these fibromyalgia, it results in these chronic pain syndromes. This is also the area that produces dopamine. Who knows what dopamine is?
It's another neurotransmitter.
Yeah, it's a neurotransmitter, that's exactly right. It's produced in the mesencephalon. Okay? Dopamine is a very powerful neurotransmitter, a very powerful reward neurotransmitter for us. It makes us feel good. In fact, there was some research done. They took some monkeys, and what they did is they attached it such that when the monkey would tap on a lever, they would either get food released, or if they tapped on the other lever, they would get a shot of dopamine. And what they found is actually the monkeys would keep hitting the one that would give them the shot of dopamine because of the euphoric feeling, and they actually would do that until they starved to death. That's how powerful this is. Dopamine is really involved with our Parkinsonian patients, has a lot to do with our basal ganglia. This area up in our brain helps with our movement disorders. Okay, so this is kind of what's going on in that upper brainstem area. So again, upper brainstem dysfunction, this kind of shows it from the top here. If we have problems with that, chronic pain, light sensitivity, migraines, restless leg, these are all associated with that substantia nigra and that mesencephalon not working properly. You guys don't need to know that. Okay. Emotional stress, I don't think you need to know this either. This is just talking about fibromyalgia. We talk about fibromyalgia with our chronic pain as well, because usually people that have had chronic migraines are diagnosed with fibromyalgia. I'm assuming that's probably happened to you. Not yet? Okay. And that's usually what happens is you're going through this test and then diagnose you with fibromyalgia. And it's just another word to describe something that there's something going wrong underneath the hood of the engine. So again, overfiring mesencephalon can lead to a lot of different problems. Your heart increasing your heart rate, catecholamines, norepinephrine, chronic pain, fatigue, sleep loss. This talks about fibromyalgia. Again, we talked about this already, the cerebellum, that area that controls the balance and coordination. of those spinal postural muscles. Okay, so what can we do about this? Well, of course, we need a thorough neurological exam, okay? Functional examination to see what's going on with you. We need to increase the frequency of firing in these areas that aren't working properly and dampening the ones that are working too much, okay? And we need to provide fuel and activation. That's really, although simple, is one of the biggest parts of these cases, is providing proper fuel and activation. So again, exercise with oxygen therapy. This is an oxygen concentrator. You can see these right in through here. This is something we do with our patients in here to help with these chronic pain syndromes. It delivers about 95% of oxygen as far as that goes. But there's tons of research out there on oxygen and oxygen therapy and the benefits that it can cause and how things it can help with. Brain-based therapy. This is analyzing you from a functional aspect and seeing which area of the brains are working properly, which are overfiring, which are underfiring, and how to address that accordingly.
And how do you do that?
Functional examination, yeah. We basically look at your cranial nerves. We're going to check your visual aspect. We're going to check your balance, your gait, a bunch of different tests we do. Blood pressure, pulse, tissue perfusion, these kind of things.
How do you see how the brain's working?
Different tests. So, for example, if you're facing me and you follow my finger to the right-hand side, I know I'm assessing what's called the right parietal lobe, the pursuit area of the right parietal lobe. If there's a breakdown of movement that tells me, something's probably not working real well right there. So we add all these things up together. So there's tons of ways to assess that. But just simply your cranial nerve exam will tell a lot as well. Facial asymmetries, sweating to one side of the body more than the other, temperature-wise, a lot of different things tells us what's going on. Eye exercises, we might do adjustments to a specific side to activate one side of the brain versus the other. Again, balance exercises, multiple stimulation at one time, vibration therapies. It just depends on what we're finding, okay? Interactive metronome, again, we talked about that. That's a computerized device that will increase that firing of that frontal lobe to dampen that overfiring mesencephalon, which is leading to these problems.
What if I say the multiple stimulation would drive me crazy? Yeah,
again, for some cases, we can't do that.
Okay.
We have to see where you are. If you're at, okay, we can handle this much and that's it, we fatigue, then that's all we can do.
Okay.
For someone that can't handle a bunch of stuff, we can't just go to bombard you because you're going to feel horrible afterwards. We got to build up to that. But there are some people that they've built up what we call plasticity, or they've gotten stronger to this point. We can challenge them more, and the more you challenge the area, then the stronger it's going to be.
Okay.
So yes, we can provide trivial stuff initially, but our goal is to get beyond trivial because we want you to develop some kind of strength.
So you can assess that as well too, without overloading me. Because,
that's what we need to do.
I mean, the last thing I want to do is come in here and leave here set back a couple of years ago where I was, which was 7-8 migraine every day.
Absolutely. Which is another reason we need to assess you metabolically. When you're telling me that you've got this issue with, that your system is this weak, you've got metabolic issues. It's just a matter of someone hasn't found them yet. Or hasn't looked in the right places, rather, I'll put it that way. Absolutely. Okay? There's definitely got to be something, especially what you told me already with your history of the thyroid stuff going on. You've got some sensitivities, you've got some stuff going on there, definitely. So to answer your question, we can't bombard you too much. You're right, yeah. You get worse. You won't feel good at all. So we have to start slow with a case like that. Oftentimes, again, with these kind of cases, there's usually neck discomfort involved with them. Not always, but a lot of times there is. So we utilize a procedure we call non-surgical spinal decompression, which is a machine that basically helps unload the joints, takes pressure off the neck joints and the cervical discs. We also can use this for chronic relief of neck pain and numbness in the arms as well.
Is it just kind of gentle traction?
Yeah, it's gentle traction, but it's a decompression, so it takes the pressure and then it offloads, take the pressure. It's not like a stretch and hold type thing. It's computerized, so it changes the pound and weightage accordingly. Real good success with this with our chronic neck patients, and obviously low back as well we use this for. ATM2, that's the machine in the back. Again, this is part of rehabbing spinal complaints. And we'll also use this people who've got weaker areas of their brain that can't control their joints very well. And we'll use that on them as well. Cold laser therapy. This is a light therapy we use on more of our chronic pain, fibromyalgia cases. But we can also use on carpal tunnel arthritis and different things like that. This is an example of cold lasers. It's kind of neat. I just throw this in there because patients find this interesting. The picture on the left is of a gentleman that came in our office after he had hit his hand with a power washer. And this is kind of pretty much very shortly after that. And we had lasered him 3 times, and that's about a week and a half later. So you can see it heals, it helps heal the tissue is basically what it does. This is another one. This is a gentleman's inner thigh. Had gotten run over by one of his cows on the farm. And he had treated this actually 2 months prior to coming in here, and it just was not healing. It was, I mean, it was probably about that deep. He treated with salves and antibiotics and everything. And him, we lasered him. This is a big hematoma underneath here, a big pooling of blood. We lasered him, cold lasered him, light therapy, and that was a month and a half later. He said after the second laser treatment, fluid just literally just kept coming out and coming out and coming out. So it's pretty interesting stuff. So my point with this is, if you can see what this does on the surface, you can imagine what it does underneath the surface of the tissue to help it heal as well. Okay, so neurotransmitters. You seem like you're familiar with those. We need to go a little bit on neurotransmitters.
Serotonin and
norepinephrine. Mm-hmm. Okay. So basically all these are is, you've got a nerve here, you've got a nerve here. So to send the message from here to here, it needs a way to communicate, so it secretes something. And that neurotransmitter transmits the message between these two synaptic clefts. Okay? So there's a bunch of different types. These are the main ones here: dopamine, GABA, serotonin, and acetylcholine. Okay? And this is how your brain communicates with different areas, specifically endocrine glands. Okay? So how many of us have had blood work and they say, well, everything looks good. Mm-hmm. Your blood work's normal. Well, I don't know why you're feeling bad, your blood work's normal. Mm-hmm. Why? Here's why. Okay, because this is interesting. People don't know this.
Okay.
We look at lab tests now a lot different than we did years ago. In fact, our lab values have changed a lot since then. And I'll have another slide on here in a minute to show you why. Your lab values are compared with your lab values, or compared with someone that's in the hospital's lab values. So in other words, they take a whole pool of people and they do a bell curve. Sick people, healthy people. Okay, well, this is about the average where we are. So now this year, this is normal. Okay? And 10 years from now, this is normal. And it's changed over the years. Okay? So once we start getting further and further away from the midline of that stuff, we start developing problems. What we call our functional ranges. Okay? We assess functional ranges in here as opposed to lab values. So for example, this would be a functional range. This would be what we would call normal values. Okay? So if your lab test would come back and you're in here, or you're in here, technically you'd still be normal, okay? But the problem is, a lot of your symptoms already start right about in here. But they're not going to diagnose you until you're here, or until you're here. Do you get me? Mm-hmm. Do you understand what I'm saying? Mm-hmm. But we'll see patients that are in this range all the time. And those chronic people that are hard to get better, that's where they are. Because they haven't really fully developed the disease, or the problem yet, but they have the whole bunch of symptoms. So the doctor says, you know, we'll keep checking it. It's not there yet. It's close, but it's not there yet, so we can't assess you for that. For example, fasting blood sugar or glucose. Okay, functional ranges with the ranges I'd like to see for you or you to be healthy, that should be between those numbers, 85 to 100. Okay, that's where it should be for you to be healthy. But the traditional high to low ranges are somewhere between here, 65 to 110. You can see there's a lot more leeway here than there is here. But if a patient comes in my office with a 73 blood sugar or even an 80 blood sugar, I know this because my wife, exactly 80 blood sugar, they have symptoms of what we call hypoglycemia. We call that reactive hypoglycemia. Not getting proper sugar enough, not sustaining the sugar, getting dizzy, getting weak, getting lightheaded, getting irritable. These kind of things happen when you're below normal ranges, but technically they're not going to diagnose you. So if you're outside the functional range and you need a proper supply of glucose to function properly, what do you think this is doing to your nervous system? This is a very basic thing, blood sugar, very basic. Mm-hmm. But if we're missing this, we're missing.
We don't have any fuel.
Exactly, we're missing a big part of this picture. This is huge. Mm-hmm. Okay, and this is often overlooked. It's the same thing with TSH, thyroid stimulating hormone. 1.8 to 3 is our functional ranges. This is a whole lot of error you can have in here for your high-low range. But if your range is up above 3.0, you got a sluggish thyroid. We know that because you're secreting more thyroid stimulating hormone to get that thing pumped up and fired up. Same with cholesterol, triglycerides, hemoglobin. I think you guys get the idea. Okay, so we're looking at the same thing. I'm a lot pickier with what I'm looking at because we're looking at you. We want to get you healthy. We're not trying to treat the disease. Okay, so again, dysglycemia, which is referred to as abnormal blood sugar, can be too high, can be too low. If it's too high, you start developing what we call metabolic syndrome, which is a precursor to diabetes. Okay, we've heard of that, type 2 diabetes. Or if it's too low, it's a reactive hypoglycemic. Oftentimes we'll see reactive hypoglycemics that have migraine headaches. It's very common. Very common. It's one of the things we look at. Okay. Determined by labs, it can be too much or too little. Again, we don't know. I can't guess. We have to have the lab work to tell. Adrenals. Adrenals are your stress gland that sit right here above your kidney. Okay, it's your sympathetic gland. And if you remember us talking about the sympathetic nervous system, that's your fight or flight. So when you're in a constant stress situation, those adrenals keep firing and keep firing and keep firing, okay? And they keep releasing things, okay? One of the things they release is what we call cortisol, which is a glucocorticoid. And it stimulates the liver to produce glucose in between meals. So that's important. So when you don't have enough glucose, this adrenal gland kicks in to release that cortisol and help more sugar be released in the bloodstream. And also what it does, it takes the peripheral tissues, stops them from taking up glucose, and it raises the blood sugar centrally. Okay? Adrenal fatigue often goes hand in hand with blood sugar issues. They're kind of like peanut butter and jelly here. Oftentimes we've got dysglycemia, we've got an adrenal issue as well we've got to treat. And people that are living on stimulants, and we all know them, okay, we might be them, they wake up in the morning, they have a cup of coffee, they have a cup of coffee at 10 o'clock, lunch. This is what they do. They toss down a Red Bull, they toss down all these other things. They're just stimulants. All they're doing is you're beating a dead horse. And you're causing more and more vasoconstriction, vasodilation. Vasoconstriction, vasodilation. Vessel open, vessel closed, vessel open. What do you think this is doing to your head and to your brain? Absolutely. This is huge. Can't overlook this. This is another aspect that be causing the problem, okay? And this is a huge aspect of a lot of cases, is if they have an autoimmune condition. Autoimmune condition is where the body attacks itself. You guys have heard of things like this, right? Rheumatoid arthritis, lupus is one of them, Hashimoto's is one of them. These are ankylosing spondylitis. These are all autoimmune conditions. These can be from food sensitivities, leaky gut, or genetic issues. Obviously, if you have the genes for it, you're predisposed to it, you need to know that. Number two, leaky gut is when the gut becomes impaired from, number one, bad eating, number two, antibiotic use that just kills the good bacteria in the gut, and then that membrane wall that you have in the gut just gets weaker and weaker, and then normal food that should go into the gut and be passed into the small intestine actually starts to leak out into the bloodstream. And your body finds it, attacks it, it's known as a foreign invader, and you keep having this constant reaction to this type of thing. These are things that need to be looked at if you're suffering from a chronic condition. Okay, so basically, these first 4 here, 5, even 6, these are really the big food sensitivities. I want to make sure we cover these because you need to know what each one is. Who knows what number 1 is? Gluten.
No. It's gooey stuff in wheat.
Yeah, that's exactly right. It's the gooey stuff in wheat. But what is wheat in?
Everything.
Toothpaste.
It's in condiments.
Yeah.
It's in soups.
Toothpaste.
It can be in you're exactly right. It can be in shampoo. It can be in tons of things that we use. You wouldn't think, well, all I have to do is stay away from bread. That's not true. Okay? If you have a gluten sensitivity, or if you have the gene that says you should not have gluten, whether it's celiac or what we call transglutaminase, you do not have to have stomach problems to have celiac disease. What the research shows us is that for every 1 person that's diagnosed with celiac disease, there's 8 other people that are not diagnosed because they don't have stomach problems, but it's affecting their body elsewhere. It can affect your thyroid. It can affect your brain, causing anxiety, depression, migraine headaches. It can affect kids that have ADHD and autism. This is what the research says, folks. We don't know unless we test. If you have this condition, it is making your health condition worse. That's it.
What I don't understand about a food sensitivity is, in my situation, I was fine without chronic migraines until 2001. And then all of a sudden, I wake up in the middle of the night with a migraine that has lasted this long.
Mm-hmm.
So
what happened up to that? Was there any emotional, physical traumas?
No.
No stress-induced anything?
No.
Okay, I mean, we have to dig into your history more, but the only thing I can tell you is, for whatever reason, you exceeded that metabolic capacity. You exceeded where your body said, okay, I can't take this anymore. How you did that, I don't know. We'd have to really dig. But the bottom, you've exceeded it. It's possible, yeah. I mean, there's research out there. I mean, it doesn't have to be that. Okay, I'll give you an example. My wife. My wife, in fact, we found this out that she's got celiac. In fact, I tested myself. I don't have any digestive problems. I'm a pretty healthy guy. Guess what? I have the gene for this stuff too. I didn't know that, but guess what? I want to know that now. Instead of 30 years or 10 years or 20 years down the road, it hits me and I start having problems with this, or this, and I don't know what it is. I already know that I need to eliminate this, okay? So for the first however many years of my life, she didn't really have any stomach problems. But more recently, within the last year, she's really developed this stuff, okay? It's kind of like it put it off as long as it can, and it's gotten too much to the point where you can't deal with it. Is that your case? Maybe.
Okay.
I don't know. But that's where you'd have to dig a little bit deeper with that.
Okay.
Number 2 is dairy. This is a common allergy. You don't know unless you test. Okay. Soy, this is a very cheap protein. It's in a lot of things. We don't know unless we test. Same thing with the rest of this stuff. So if you're not testing these things and you have a chronic condition, you got to start here.
Is it blood tests? Or?
What we do in here is it's a DNA test, okay, and it's a stool analysis as well when we test all these here. So you'll do the swab for the DNA aspect of it. We do it through a lab out of Texas. Yeah. And that'll tell us genetically if you have the genes, and also it tells us what your reaction is via the stool. We also test, another thing we do is through a lab is we'll do parasitic testing as well, because if you have a parasite or something going on, or abnormal yeast overgrowth or things of that nature, that could be driving your immune system to overreact as well. These are things we need to know. Absolutely. So, do you have an autoimmune condition? Do you suffer from adrenal fatigue? Are there food sensitivities? Until you really determine what's going on, we can't really treat your condition properly. We're guessing at best. That's what we're doing. So I don't have to be the smartest guy. I just need good information. And that's what we need to look where other people aren't looking. And you need the fuel to drive the car. And oftentimes this metabolic aspect is the missing link with these hard, let's roll up our sleeves and get at it cases. These are difficult cases. Okay, so another thing we do in our office is we utilize what we call glutathione. Have you guys heard of this?
No.
Glutathione. It's the most powerful, potent, prevalent antioxidant in your body. And there is absolutely oodles of research out there about this. Okay? This neutralizes what we call free radicals. What's a free radical?
Something bad.
Well, yeah, that's exactly right.
Toxins, I guess.
What a free radical is
Floating
simply what it is an unpaired electron. Okay,
Mm.
so when we consume things that have that are processed, that have artificial sweeteners in, that have preservatives in, they produce free radicals. And the whole goal of a free radical is it needs a mate. So what it does is it basically goes in and it breaks up the electron transport chain, or the electron chain of other healthy cells in your body to become stable. So it kills healthy cells, in a nutshell is what it does. That's what a free radical is. So glutathione basically beats up these free radicals, helps take care of them. But here's the bad news. As you begin to decrease your by 10 to 15% per decade, your production of it, by the age of 20. This is a big problem for us, okay? And this isn't something you can just take in a pill, glutathione, because it's not absorbed properly. It has to be taken a couple different ways. So lower levels can result in chronic illness, more inflammation, which again, inflammation stems a lot of our processes. Inflammation is basically the reason we have a lot of the diseases we have. It starts with inflammation, okay? Joint aches and pains. When we can increase these levels, you're going to have more energy, your immune system's going to get stronger. You get the idea here. A lot of good stuff can happen. So how do we do this? A couple different ways. One of the things we can do is we can increase the intake of foods that help us make more of our own glutathione, which would be the first thing we should do. Okay? Sulfur-rich foods, such as these things right here. Again, here comes exercise again. That's why it's so very important. Just another benefit of exercises. Help increase your own glutathione production. Selenium, which is found in Brazil nuts, beef, turkey, and tuna. We need to increase what's called alpha-lipoic acid. Things that are found in those green stuff, spinach and vegetables. The more raw items, the better. When you cook these things, you're depleting the nutrients. Bad things happen. Okay. N-acetylcysteine is found in egg yolks. Egg yolks, that's the best part of the egg. You know, all the stuff, the good stuff is actually located in there. It's brain food, those eggs. And this helps with increasing glutathione. Okay, so we utilize the results from your blood work to provide natural supplements to aid in correction. So again, we'll look at the labs, we'll check for sensitivities. If you have nutritional deficiencies, we'll treat them with nutrition. We treat them with supplements and different things like that that have been researched and documented that help with this problem or that problem. So in other words, if someone has a high blood sugar issue or a type 2 diabetes, we give them what we call glycine, which has a bunch of cofactors that help basically lower blood sugar. It's phenomenal. Really neat stuff. So again, neurotransmitter support, blood sugar support, adrenal support, different supplements for different conditions. So we have all these pieces, and that's why I said it's never one thing. We got to look at the whole thing. Is it the cerebellum? Is it your blood sugar, cortisol? Is there oxygen issues? Is it that mesencephalon overfiring? Is it hormonal imbalances? We got to put the pieces of the puzzle together, and then we periodically retest. We can bring everything back together, so we know we're on the right track. Obviously, we need to assess symptoms as well. Okay. So how do we screen for these kind of things? I think we were talking about this a little bit earlier. What kind of tests do you do? One of them is we're going to be looking for what we call blepharospasm, or a spontaneous eyelid twitch. We'll do a Romberg examination where we have you stand with your feet together, checking for any kind of sway. If there's sway with your feet together, you've got weakness in the system. Your vestibular system is not working properly. Okay, finger to nose, this kind of test. Okay, if we get one of these, you don't know where that is. There's a problem. There's a breakdown in those areas of the brain.
You close your eyes when you do it?
Absolutely, yeah.
If you've been through the neurological tests, do you have to go through them again, and could you only focus on the metabolic?
Unless you had gone through with a functional neurologist, I would say we'd have to do a functional neurologist or a regular medical neurologist.
I've been to UVA, I've been to Johns Hopkins, I've been to North Carolina.
Yeah, the main thing I would say is this: they're looking for basically huge, drastic lesions. They're looking for ablative lesions. Okay, I'm looking for subtleties that can tell me something else is going on. Kind of goes back to that functional nutrition aspect of it too. Okay, where they're looking for big discrepancies. I'm looking for small things that can create a big picture for me. So that's why we're looking at it just a little bit different. Optokinetic response is kind of like a big Dr. Seuss hat, red and white strips, and it tells us again what's going on with the eye movements. Eye movements tell us a lot to what's going on with the brain. So just different tests that we do here to see what's going on. Questionnaire we give you gives us more of an insight of how your body's functioning and what's going on, what's going right, what's going wrong with your body. So again, this is only powerful if you use it, and if you always do what you've always done, you always get what you've always gotten. And insanity is doing the same thing over and over, yet expecting different results.